Thank you for joining us today for a brief discussion on ICD-10 PCS coding of bimalleolar and trimalleolar fractures, presented by Libman Education. My name is Lynn Keene, and I'll be presenting this topic. Bimalleolar and trimalleolar fractures can be hard to visualize, making the coding more challenging. So the first thing we need to understand is the anatomy involved. For that, we will turn to this labeled image from the Boston Medical Center. There are three individual bones that make up the ankle joint. They are the tibia, the fibula, and the talus. The medial malleolus is the outer part of the tibia bone, and the lateral malleolus is the outer part of the fibula bone. Together, they are called malleoli, the plural form of malleolus, named after the Latin word for mallet. The fibula has one malleolus on the lateral side, and the tibia has two malleoli, one on the medial side and one on the posterior side. The fractures that we are discussing today are of the individual tibia and fibula bones at their malleoli, not of the ankle joint. The ankle joint does not actually break. It can become subluxed, meaning partially dislocated, or completely dislocated along with the fractures of the bones, or without a concurrent fracture. An ankle dislocation would mean that the talus is out of position compared to the tibia and fibula, or the joint between the tibia and fibula has separated. This joint is called the syndesmosis. The syndesmosis is formed by the ligaments that hold the two bones together into position, the anterior inferior tibiofibular ligament and the posterior inferior tibiofibular ligament. If these ligaments are torn or stretched, the documentation will likely call this an ankle sprain or a syndesmosis disruption, depending on the severity. I'll talk more about the syndesmosis after we discuss the fractures. Now let's take a look at those specific fractures. On the left-hand side, the bimalleolar fracture is shown. It is a bimalleolar fracture because two malleoli are fractured, one of each bone. They are the lateral malleolus of the fibula and the posterior malleolus of the tibia. The challenge here is that the surgeon will probably call this an ankle fracture, but in PCS, it is coded as reposition of the individual bone fractures. You can see the small piece of the tibia that's broken off the posterior malleolus and the larger piece of the fibula that is broken off the lateral malleolus. This is a classic break for a bimalleolar fracture. Both of these bones need to be repositioned, and the reposition codes for each fracture would include the internal or external fixation device chosen by the surgeon. Now look at the image on the right side. The trimalleolar fracture gets its name from the three breaks that take place, two in the tibia and one in the fibula. And again, these are the classic break patterns. Again, both of these bones need to be repositioned. There is only one code for the tibia, even though there are two fractures of that bone, and another code for the fibula. Before we leave this image, let's look at the syndesmosis of the ankle in each image. On the left, the image shows the talus out of position in comparison to the tibia. The documentation will likely identify the ankle subluxation or dislocation and the repositioning of this portion of the joint. This would be coded as a separate reposition code for the ankle joint when repositioning is documented. On the right drawing, it appears that there is no ankle subluxation or dislocation that requires repositioning. Documentation will likely say that the ankle joint or syndesmosis is stable or undisrupted, and no code is necessary for the ankle joint. let's look at what the repositioning of the joint would look like. If there are no fractures involved, an internal fixation device can be applied across that part of the ankle joint from the fibular side. In this case, only the repositioning of the ankle joint is coded, and the hardware is an internal fixation device. This is shown on the left. If the syndesmosis is disrupted with an associated malleolar fracture, a combination internal fixation device can be used to reposition the malleolar fracture or fractures and the syndesmosis. This is shown on the right with one long screw spanning the syndesmosis to hold the joint in position. The diagnosis code indexing for malleolar fractures is unusual and a little bit misleading. The index refers to these as fractures of the ankle under fracture traumatic ankle, and then either the bimalleolar or trimalleolar fracture. Yet the index entries lead you to a code that correctly describes these as lower leg fractures. So in summary, the physicians may refer to these as ankle fractures. That's not an issue. Just remember that the repositioning of the malleolar fractures is repositioning of the bones. The syndesmosis dislocation is a separate issue of the ankle joint, and if repositioned, that is coded separately as an ankle joint repositioning. Here is a sample report that describes the treatment of a left trimalleolar fracture. The left ankle syndesmosis is also disrupted on exam. Both bones are repositioned and treated with internal fixation. The syndesmosis was repositioned, and the screws were placed through the lateral plate on the fibula across the joint. The coding for this is typical. The patient had a displaced trimalleolar fracture, and this is the initial encounter, code S82.852A. The patient fell, but no other details are available, code W19.XXXA. The reposition codes identify the fibula, code 0QSK04Z, the tibia, code 0QSH04Z, and the ankle joint, code 0SSG04Z. I hope this explanation and case documentation have helped. For additional coding education on inpatient trauma cases, we have resources available from Lebanon Education. We have PCS trauma procedure coding, CM trauma diagnosis coding, and for the best value, the complete trauma coding education package in the trauma e-learning library.